Hello, welcome. This is Dr. Michael. Today we're going to discuss yet another important medical emergency, and this is acute asthma attack. Very common. So what do we mean by an acute asthma attack? We refer to a deterioration of the baseline asthma control that usually leads to an acute wheeze, shortness of breath, and dyspnea. So what are the common causes of an acute asthma attack? We could have upper respiratory tract infection, especially those of viral origin. We could have shortage of asthma drugs, exposure to triggers the likes of coldness, dust, smoke, etc. It could also be stressful moments. What are the signs and symptoms of a patient having an acute asthma attack? Patient may present with a dry cough, may be a nocturnal paroxysmal cough, chest tightness. They may have a dyspnea, there may be an evident wheeze. On examination, when you examine, you may reveal a quiet chest. There may also be features of a decreased oxygen circulation, although this may be suggestive of severe asthmatic attack. Complications: we may have a pneumothorax. We may also have a status asthmaticus as a common complication of this. By status asthmaticus, we simply mean an intractable or an uncontrollable asthmatic crisis, usually associated with severe bronchospasms. How do we investigate a patient with acute asthmatic attack? We can do a complete blood count, we can do arterial blood gases, we can do a chest X-ray, which is most likely to reveal a hyperinflated lung. We could as well do spirometry. So the management of a patient having an acute exacerbation of asthma, of course we have to start the treatment very immediately, maintain the patient in a semi-seated position, supply oxygen to ensure that the oxygen saturation is above 90, initiate short-acting beta-2 agonists, usually by nebulization. For example, we may give salbutamol, maybe 5 mg and 5 ml of normal saline. It's over 10 minutes, and you may wish to repeat like 1 hour later, although you can continue nebulizing depending on the need for it. You can administer an intravenous steroid, hydrocortisone, 100 mg given 6-hourly. You assess the need for ventilation as according to the response of the patient to the therapy. You try as your level best to avoid triggering agents, if of course it is known. You as well educate the patient on the medication and other strategies of avoiding a recurrence. Now, a status asthmaticus, which is one of the most important complications of an acute exacerbated asthma. How do we manage it? You assess the ABC, that is airway, breathing and circulation. You of course ensure that you provide 100% oxygen. Then you give salbutamol intravenously, that is at 0.5 mg per hour. You can as well give hydrocortisone 200 mg IV given bolus. If our patient is not responding to any of those above, you administer adrenaline at 0.1 mg given IV bolus, followed by magnesium sulfate 2 grams IV given over 20 minutes. This one of course reduces the severity of the bronchospasms. If still the patient is not responding to adrenaline and magnesium sulfate, you may wish to consider intubation and of course mechanical ventilation. It's under sedation with ketamine, which is usually given at 1 to 2 mg per kilogram IV. Note the following: try your level best in a patient of this kind to avoid sedatives or aminophrin. You can give anticholinergic drugs such as ipratropium bromide in case you have excessive respiratory secretions. Monitor other hemodynamic parameters and other vitals that are indicating severity. And our major recommendation is always refer a patient of this kind to a tertiary institution in case there is failure of all the above therapy for acute asthma, or if there are features suggestive of a developing status asthmaticus. Dr. Michael remains my name. Continue subscribing to our YouTube channel, the Doc Education channel, For this and more of the videos,